My name is Leon Herndon, Chief of the Glaucoma Division at the Duke Eye Center in Durham, North Carolina. Welcome to our fourth installment of our Duke Glaucoma Surgery Series. And today we're going to concentrate on tube complications. So everything you might want to know about how to deal with things that go wrong with tube surgery, we'll discuss with this panel today. I want to thank J&J for supporting our event today. I want to thank all of you all for chiming in. And I'd like to introduce our faculty today. I'm pleased to have Dr. Pratap Chawla, who is associate professor at Duke. Welcome, Pratap. I'd like also to introduce Dr. Stuart McKinnon, associate professor at Duke. Welcome, Stuart. I'd like to introduce you to Julia Rosedahl, associate professor at Duke. Welcome, Julia. And Duke, final Duke faculty is Joanne Nguyen, associate professor at Duke. Welcome, Joanne. It gives me great honor to introduce our two guest faculty who both did their fellowships here at Duke several years ago. Samir Ahmed, who is in private practice of the Glaucoma Consultants of Washington in Herndon, Virginia. Samir did his fellowship here at Duke in 2003, 2004. He also is a part-time faculty at Howard University and adjunct faculty at University of Maryland. And Samir spent 2 years in Saudi Arabia at Kokesh, and he always told me about the complex issues he had to deal with there. So we look forward to his experience. Welcome, Samir. And we also have Shane Havens. Shane did his fellowship at Duke 2013 to 2014. He's in private practice at Eye Consultants in Omaha, Nebraska, and is adjunct assistant professor of ophthalmology at the University of Nebraska and faculty at the Omaha VA in Nebraska. Welcome, Shane. This program would not be possible without the input from our fellows. We have two of our fellows today who have helped to put this program together. I'd like to introduce you all to James Liu. James is from Tucson, Arizona, and he's a first-year fellow with us. Welcome, James. I also would like to introduce and welcome Sarah Xu. Sarah is from Wuhan, China, and also is a first-year fellow with us at Duke. Welcome, Sarah. So as attendees, you all will have the opportunity to ask us questions as we go along. Again, we have a lot of room, a lot of areas to cover. And to explain the communication piece, I'll ask Joanne Nguyen to touch base with our group to let you know how to communicate with us. Joanne?
Sure. Hi, everybody. Can you guys see me okay?
Yeah.
Perfect. Just so everybody knows, there is a Q&A function at the bottom of your Zoom panel. If you have any questions or comments, feel free to submit those. We will try and answer those as timely as possible. If not live as we're going through the presentation, we'll try and type in answers if we can as well. Also, let me know if there's any questions or concerns through that feature.
Great. All right, we got a lot of ground to cover. We'll probably be here about 2 hours. Stay as long as you can. At this time, I'll turn it over to James Liu.
All right, thanks for the introduction. Glad to be here for another one of these surgical webinars. So during our last session, we looked at the basics of glaucoma drainage devices. Today, we're going to be focusing on tube management and troubleshooting. Particularly, we'll look at how to manage over-filtration and under-filtration, dealing with tube-related visual disturbances, adjusting a malpositioned tube, and managing tube erosions and tube-related infections. So we'll begin with a brief overview of these topics, and then we'll jump into some case presentations and discussion from our expert panelists on their preferred management and treatment. As mentioned, we're fortunate to have several glaucoma experts here today. We even have a cornea specialist present for this conference as well. I've been told glaucoma and cornea is a very symbiotic relationship. Our tubes may cause some corneal issues, while their surgeries and steroid drops may cause some glaucoma. So often we're co-managing patients it'll be good to get their insight as well. Okay, so to start, we'll look at what to do when the tube is functioning too well. So wound leak is an obvious early cause of hypotony. Sometimes the closure can look great, but at times tenons may be caught in the closure site and act as a wick. Here we're showing some Seidel positivity at this wound closure, so it's very important to check these sites carefully early. Early hypotony may also be a result of how the tube is prepared in the surgery. So for non-valved implants, the tube is often tied off initially to prevent early hypotony. Fenestrations and suture wicks through the tube are needed to provide some initial flow. This can be very finicky to titrate, and I still haven't seen the magic combination of wicks and venting slits that works in all cases.
Let me stop you there, James.
Yeah.
So let me ask the panelists. So I did not always use ripcords with my non-valve tubes, but over the past several years, 10 years. So James, if you show us what the ripcord is, and for those in the call who might not be used to doing these types of tubes.
So here's a video of that ripcord.
Yeah, so this is the case that that I did where the ripcord slipped. Pause there. Pause. Okay. So if you stop there, you can see the ripcord, in this case, a 6-0 proline. And you want to be really careful when you manipulate. You don't want to slip that ripcord out as the system that's pulling the tenons here. Unfortunately, this ripcord gets pulled. And so stop there. Stop there. So what do you do now, Samir? Now you have a ripcord that's been pushed or pulled beyond the vicral ligature. What's your approach to replacing this?
Well, this is always a tough situation. You're about to finish up. You take your pulse, deep breath, and don't panic, right? So I've gone to one extreme of just trying to, if there's good exposure, like I see here, maybe try to place it back to see if you can get it more anterior, and then you can maybe do another vicral ligature. Let's say it's anterior enough where you can do another ligature. One option is to then use the external approach. Paul Lee taught me that technique where you put the ripcord next to the tube and tie it down. In worst case scenario, you just cut your stitch and pull the implant out anteriorly, put the ripcord back, tell the fellow next time it's I'm not going to let you do it, and then just suture it back and then press on.
Yeah, I think it's really important with these, when you're using ripcord, as soon as you can, as soon as you apply the plate to the sclera, you want to tuck that ripcord as soon as possible so you don't run into this situation. Let's see what happened, James. So most times you can slide this just back in place. It's important to make that tube taut. So I have instruct the fellow to kind of pull the tube tightly and make it straight. And in this case, it slipped right back in place very easily. And so we got lucky in this case, did not have to open up the vicral ligature. There's another example, James. Dr. Chawla, I think you were involved with this case.
I believe so. Let's see. Oh yeah, so this one, the ripcord slipped out, and then we just basically put the ripcord next to the tube. Oh, okay. Well, this is a different one then. Sort of slid it back the other direction, yeah.
I think you try to reinsert it initially, but it doesn't seem like it gets past the ligature.
Okay. Sometimes it does, like Leon was mentioning. Sometimes you can sneak it in there, but sometimes it doesn't. So then we just tied it from the outside here. And I think that's what Samir was describing earlier, was tying an external ripcord. And
Okay,
test it obviously after you do that.
great. Thank you, James.
So going back to some of the other issues that we might see, there's also issues with the tube preparation, as we've mentioned. Apologies. In addition to kind of getting the fenestrations just right, or the right number, you may accidentally slice the tube too aggressively and kind of truncate it or cut it, or create a partial thickness kind of tear through it. So we sort of have an example here where we have an overexuberant venting slit and potentially the management there. So as you can see, as we're injecting here, there's leakage through that tube, more so than ideal. At this point, what would our panelists do to adjust for this?
Shane, what would you do if you have a large venting slit? So you see in this case, the anterior chamber keeps shallowing. Do you just take the tube out and go to a different quadrant? How do you rescue this?
There'd be a couple options from my standpoint. If you felt like the remainder of the tube was in good enough shape, you could potentially put a vicryl suture over it. But another option would be to even transect the tube and use a 22 gauge angiocath over that area to kind of bridge the area that is macerated. Otherwise, I think, if the tube's in disrepair, you might have to, you could utilize a tube extender and cut short of your tube opening. But I think those would be the options I would consider, either direct closure or a coverage with angiocath.
All right, let's see what happened. Yeah, we're microsurgeons, so I thought we could repair the tube. So we use a 10-0 nylon on the BV needle just to make a repair of that large venting slit. So in this case, it worked out. If it didn't, I guess you could place a 7 vicryl ligature anterior to this. But that's one option for you if you find that you have a case where overfiltration from a large venting slit.
These happen most commonly because the venting slips should be 50% down the width of the tube. If they're too high or too low, you end up cutting a tube a little too closely and you get a much larger opening than you plan to. So
that's exactly right. I always tell the fellows, make sure you're staying right in the middle of the tube. You don't want to go to either side, or this could happen. Samir, you had a comment?
It's not a disaster to say, let's take the whole plate out and put a new one. If it were my eye and I saw this happen, you'd say maybe instead of doing too much to save it, just take it out.
Right.
Stakes are too high for future, right?
Yeah, that's a good option. Okay, James.
And then, of course, the tube may not be tied off tightly enough. So here's an example of that. This is after the ligature has been done and we're flushing the tube, but you can see a little trickle out this way, suggesting that it's not closed off enough. So this would probably need another ligature to be placed in such an instance. Hypotony can also occur once the tube opens a few weeks out. Patients may often describe sudden blurring of vision or maybe some discomfort. This occurs at the 6-month marker around that time, so one needs to be vigilant during the post-operative course for concerning symptoms. And then, as we've mentioned, we can have various ripcord malfunctions as well.
James, I think you meant to say 6 weeks.
6 weeks, yes, apologies.
Okay.
That's correct. So in terms of management for overfiltration, we've seen some of the ways to revise these things intraoperatively, but are there any techniques out there to correct overfiltration postoperatively? One thing that has been described is revising the tube by stenting it with a suture and restricting the flow through it. So this is a case report describing ab interno tube occlusion with a 4O proline suture. The suture is fed through the lumen of an overfiltering tube, and one can see the improvement in the IOP following that procedure, as well as the improvement in visual acuity afterwards. Some may even cauterize the tip of the suture to create a little bulb, though they did not in this case. There is obviously concern that you may plug it up too much, especially with a bulb tip. So once again, you need to monitor these things carefully post-operatively. Other ways to revise the tube would be to externalize it and tie it off. This was the preferred technique in a retrospective case series done at Duke. As one might expect, cases where the tube was tied off with a more permanent proline ligature provided more reliable IOP reversal compared to a vicryl.
And we had a quick question from our Q&A. Someone was wanting to know, is it a reasonable idea to place 2 ligatures as a precaution in all cases?
Julia, what do you think about that?
I think that if you're pretty confident with your, your initial ligature, I'm not sure, how much a second one would give you. I do like to kind of do an extra wrap if I'm not feeling like, that flow is completely restricted, with my vicryl. But I think one ligature with, good tight nuts, that should be pretty significant, pretty good. One of the other things I think of, in the overfiltration situation, if you think it's self-limiting, that overfiltration, like you just need to give it a little bit more time for that capsule to form around that plate. Sometimes some viscoelastic, especially a more dense one, you can put that into the AC at the slit lamp, and that can buy you some time as well if you think it's a self-limited overfiltration situation. Oh, sorry about that, James.
No, you help me transition to the next one, which is when you do have, sometimes you may have hypotony, or you may be concerned about that, and you potentially could fill either in the OR before your surgery is complete, or if afterwards you do have hypotony and AC shallowing, then it may require a slit lamp refilling of Helon or going back to the OR. Additional things to manage. One may eventually need to just remove the implant to prevent overfiltration. We'll see an example of that in one of our later case presentations. And then lastly, one may be dealing with the consequences of hypotony, possibly requiring choroidal drainage, and we'll see an example of that as well.
So another question on the lines of tying off tubes. Someone's wondering, has the faculty noticed any more difficulty in tying off the new ClearPath tube versus the barbell tube?
Well, it's interesting. I've had a lot of experience with the Ahmed ClearPath, and my fellows tell me it is a little more difficult to tie it off than a bar belt. I haven't noticed a difference, but how many of our panelists have a lot of experience with the ClearPaths?
I've been using them, and I haven't noticed any difference myself between the two. I do kind of like how you can set the suture on the edge of the little foot plates, so it's that the end doesn't fly around when you're trying to grab it. You can kind of hook it in there nicely.
I agree. I haven't noticed much of a difference.
James, one last comment. You can sometimes consider a 2-stage procedure if they're overfiltering and hypotenuse. You can remove the tube, tuck it back under the plate, and secure it, and then just wait maybe a couple of months, let the eye repressurize, and then go back once you're confident that the capsule is formed and replace the tube. And that is fairly straightforward because the plate is already, there.
And where do you tuck the tube exactly?
Well, you can do a little dissection and kind of actually get it under the plate, and just secure it with a 10-0 nylon. So that,
Stuart, how about just ligating it with a proline in the anterior chamber? You'll have the same net effect. And then 2 months, 6 months later, like Paul Palmberg talks about, melt the belt, and that avoids a second trip to the OR.
That's another great option.
All right. Now on the opposite side of things, the tube may not be flowing well enough. Some causes for that include problems, again, with preparing the tube. Again, we try to titrate the number of wicks and venting slits to get that Goldilocks amount of flow, but that can be challenging. In our last surgery series, we showed some evidence that using nylon wicks, as is in this case, may reduce the risk of initial under-filtration compared to Vicryl wicks. The tube may also be clogged. So it can be clogged by iris, fibrin, vitreous, or heme. This is a video from Dr. Ahmad on his management for a large clot blocking the tube flow.
Samir, why don't you talk us through the case?
So this was a monocular NBG patient doing fine the first day because I like to fill up visco in the AC, but post-op day 2 to 5, I just filled up with blood. Pressure started going up, so we just couldn't sit on him. So we had to take him back to the OR. The clot was so organized that we said, let's use the vitrector. You can see here with just visco, vitrectomy, visco, vitrectomy until you could see the tube. Then I get the needle, you'll see that coming up to just tease away some of the clot at the tip. And then just like our externalization technique, I think we'll show later. So here's the needle, just really trying to break up that organized clot till I can see the tube, make the para, externalize the tube. More vitrectomy, just really trying to get that clot. And then I think here you see where we externalize the tube. And I'm using, at first, a 30 gauge needle. It didn't work, so just a 27 gauge I found to be a lot better. People worry that you're going to damage the tube. These tubes are pretty resilient with the vitrector as well. And then finally, I see the tube, so I'm externalizing it here. And then just, I like this fluorescein trick, when I irrigate my tubes, and you can see the tube's patent there. If you just watch, it's pretty neat at the end. The fluorescein is just all over, so you've got a patent tube and close up, and this has worked well for me. Thankfully, I don't have to do this a lot, but I find it difficult. And this is anti-VEGF because this patient didn't get it before the surgery, which I think prevention is all about stopping these complications. And here's just a nice result.
That's nice, Samir. Yeah.
So another instance of plugging might be some viscoelastic agent. This is a video of Dr. Herndon's, if you wanted to walk us through that one.
Yeah, this is a patient that had a Barbell 350 probably 2 or 3 weeks prior, and his anterior chamber continued to shallow. I did reform. I think Julia mentioned as an option with Hilon GV, but a week later, his pressure was still in the 40s. So you can see we took him back to the OR, and a week later, he still has viscoelastic in the anterior chamber that flushed out nicely. So that viscoelastic might hang around longer than you think.
Also for valve implants, there can be difficulties with the valve itself. So the valve may be damaged or incompetent and restrict adequate flow. The valve may also not have been primed before the implantation. Yeah. This is a video from the last seminar showing that priming process. If for whatever reason it was forgotten to prime the tube, do we have any thoughts about what we would do after the fact? Will that tube open up spontaneously?
Pratat, what are your thoughts?
Well, the opening pressure for these valves is pretty high, so you have to make sure you flush them and flush them adequately when do that. But if the valve, although I'll say lately, pretty much all the valve mechanisms seem to be working fine, but in the past, sometimes there was differential quality in them, and sometimes it would take a little bit of, some of them would have too high of an opening pressure, and so you'd have to end up just picking a different one, just switching it for another one. But now I think the valve mechanisms are all quite good, actually, nowadays.
And I believe I heard someone mention that even if it's not primed and you sort of implant it and realize it after the fact, eventually it does open up without priming. Is that true, or does anyone have any support or evidence against that?
Haven't tried not priming it.
Yeah, it's hit or miss. I mean, if you look, actually, the opening pressure for these valves can be as high as 100 millimeters of mercury. So
Yeah.
you're not going to reach that with the eye. And so rarely, sometimes when they don't seem to work as well, you can try to massage the eye with a slit lamp, but that's very rare that that happens. If you have to, I prime them all, basically prime all of them.
All right. High pressure may also occur during the hypertensive phase or because of eventual encapsulation. This may be managed by early aqueous suppression to blunt that hypertensive phase, and is in theory going to reduce the risk of encapsulation forming. There's some debate about the effect of the steroids. This is a prospective study from the Journal of Glaucoma showing that the hypertensive phase was often seen in patients treated with post-operative steroid drops compared to topical NSAIDs with more frequency. So they actually suggest that steroids are at least part of the reason for that hypertensive phase. Regarding the management for under-filtration, it really depends on the issue. If it's clogged, as we've seen, the tube needs to be unclogged. This may occur over time if heme dissolves or fibrin dissolves, possibly with YAG laser or with a procedure, as we've seen in some of our examples. And then the tube may need to be revised or exchanged if the flow is inadequate. And of course, the pressure control can be augmented with topical medications, especially during that hypertensive phase.
We did have a question. Yeah. Oh, I'll just jump in. We had a question about, does anyone use mitomycin C intra-op and post-op for OMIDs to prevent hypertensive phase? And then just to mention, there was a question about the eye watch. We will have more discussion about that a little bit later when I think we can address some of these questions a little more thoroughly, or excuse me, give you some of the answers more thoroughly. So circling back, anyone using mitomycin C intra-op, I can say I personally do not. I think some of the data out of UCSF with Ying Han looked quite interesting, and Dr. Alvarado looked quite interesting and worth looking into, but I don't know if any of my colleagues have tried it at all.
During the last session at the end of August with Yvonne O, who was on the panel, she does like that technique and discussed it extensively. So I would encourage that person who asked that question to go back and review that presentation. I think that we've got it recorded and available because Yvonne's discussion and her experience, I think, was really useful. So I'd encourage people to look back at that.
Yeah, thanks, Julie. That's a reminder. So all the attendings will get a copy of this this recording, this webinar, in a few days, and we have all the previous webinars available as well.
Another question on OMID hypertensive phase. Someone asks, is any thoughts on the use of Ropressa given its anti-fibrotic mechanism in addition to the use of COSOP to reduce the risk of hypertensive phase?
Pratap?
Well, there's no study that shows it, but Ropressa has been shown, and actually I think it's in publication now, we're just about to come out, but that it's very effective in steroid-induced glaucoma. And so theoretically, yes, it should work, but there's no published data on it working better than anything else. So.
All right. Briefly, I wanted to touch on some of the visual disturbances that may occur during or after tube surgery. Tube length can be an issue. In a case like this, the tube is directly in the visual axis and can certainly lead to some distortion. And corneal edema as well can occur due to direct tube trauma or pressure-related effects. We'll go over the management of these long tubes and corneal edema later in this presentation. The other issue that may occur would be diplopia. So this is not rare after tube surgery. In the TVT study, for example, new onset diplopia, persistent diplopia occurred in about 5% after tube surgery, whereas there was no increase in the TRAB group. New onset motility or worsened strabismus occurred in about 10% in the tube group, no increase in the TRAB group. So there are several potential causes for this, including the mechanical effects of a large bleb, muscles stretching from the foot plates of a large implant, and then direct trauma and fibrosis around the muscles. Conservative treatment would include patching or prism. However, surgical intervention often requires both strabismus surgery and surgery around the implant. So in this retrospective review, most patients had the capsule excised in addition to having had eye muscle surgery. So it may be best to kind of see a strabismus surgeon during these challenging cases. So now I will pass it off to my colleague, Dr. Xu, who will cover the difficulties of tube placement as well as the associated complications.
Great. Thanks so much, James. So next we'll be focusing on tube troubles. First, too short. So open up with a case of a 63-year-old gentleman with severe POAG who had a trabeculectomy in the past, and then subsequently a phaco tube, a bare valve. A low blood was seen over the tube area with a short tube likely occluded by fibrin or iris. A YAG laser was attempted to open the tube tip. This was not successful. The subsequent plan was to perform a tube revision with the use of a tube extender. So here's a picture of the tube extender. Again, so the common causes for when tube is too short could be from initial overtrim and initial surgery, could be the suture, the ligation suture transecting the tube. It could be also from a tube retraction or tube repositioning, such as in a subsequent surgery needing to reposition that tube from one quadrant to a different quadrant. A plate being too loose, causing the tube to again retract and the plate itself move as well. Could be a trim by another anterior segment surgery, and some of us have seen that in the past with our corneal colleagues.
So we'll make sure when our corneal colleague comes on in about 5 minutes to ask him why they trimmed those tubes too short for us.
Okay, sounds good. And we've shown here an Ahmed tube extender. We'll be showing a more detailed video of that a little bit later. The other solution Dr. Havens has alluded to is a 22 gauge angio catheter shown here. And it's used like a connector to extend the tube, depicted in this figure here. Here it is inside the eye, again covered by a patch graft of your choice. And this is a video of Dr. Herndon. The first initially attempt with a Crawford tube, then by an Ahmed tube extender. It's narrated.
This is the case of a patient with severe glaucoma in his left eye who had had an inferior nasal barbell 350 placed a few months prior to the sulcus, but the tube continued to be blocked by iris, and so the plan was to reposition the tube to in front of the iris. Once the tube was withdrawn from the eye, it was clear that the tube was completely transected. The thoughts are that the transection was due to the very tight 7/0 vicral ligature. So at this stage, to try to salvage the procedure in the patient who truly needs low pressures, we decided to try Crawford tubing first, but it was kind of tight when this tube was tried to be placed to the cut end of the barbell. So the end of the Crawford was splayed open with a super sharp to perhaps allow more space for a firm connection with the cut stub of the barbell. I did not feel comfortable that the connection would be secure. So attention was then turned to a New World Medical tube extender. The tube extender does have a bulky plate, and I initially tried to avoid this in this inferior nasal space with Crawford tubing, but it was clear that the Crawford tubing would not work. Once the bevel is cut, the tube extender is then repositioned through the new sclerostomy in front of the iris. The connection, however, to the cut end of the barbell tube was fairly tight, because of the plate of the New World Medical tube extender. So I decided to trim the New World Medical tube extender to allow for good connection to the cut tube of the bar belt. I secured this connection with a 10-0 nylon suture and then attached a plate to the sclera with 2 interrupted 10-0 nylon sutures through the plate. Again, there is some bulkiness to the plate, but we felt good that the connection was secure, and eventually we will cover this with the patch graft material. In this case, I used a half-moon corneal patch graft to cover the tube extender.
Okay, sir, let's stop there. So obviously a tough case. I guess I could have taken the whole device out and placed another one. Would anyone else have handled this differently? Shane?
Yeah, I think this was a beautifully managed, very challenging case with the transection of your tube being so close to your plate. The angiocath, would be a reasonable option just because it has a fairly low profile and you can kind of customize the length of it using the tube you have on the field as well. It takes a little extra suturing, but you don't have the big bulky plate to suture the sclera and can do a cross stitch over the angiocath to hold it in nice position. But I think, it looks like this had a nice outcome otherwise.
Leon, just want to ask you about the cornea patch graft. I've seen sometimes in complex cases like this, wound dehiscence, over cornea because of just the surface of the cornea versus sclera. Has anyone noted that? Shied away sometimes in complex cases.
Yeah, absolutely. So it's not unusual to get a conj wound dehiscence over this. It's always side L negative. And I, knock on wood, haven't had any trouble with that healing. So just increased lubrication, ointments, and they typically heal nicely. But you do see that with the corneal patch graft. I think we're going to get back into some other patch graft material later.
I will note that anti-VEGF injections in patients, they have a really tough time healing over cornea. So you're absolutely right. Cornea is harder to heal over.
Okay, Sarah.
Yeah, thanks so much. So now we move on to the cases when the tube is too long. The common causes could be the initial under trim. Another cause could be the tube repositioning, such as from the anterior chamber into the sulcus, leaving the tube now too long. Some of the technique have included externalizing and trimming. This will be showing this technique in a little bit later in our video cases. Another technique that Dr. Asrani and our team have published is regarding an ab internal trim by holding the needle with holding tube with a 30 gauge needle, providing rigidity, and then trimming ab internally. So next we moved on to when
sorry to interrupt, before we get to that case, we had a question come in if we could have treated that last case with Dr. Herndon as a shocket procedure since your capsule is already so well defined as an alternative.
Yeah, Gail, I mean, that's a good idea. So a shocket tube is, I could have just rerouted the Crawford tubing into the bleb capsule, as we typically do those off after scleral buccal procedures. Did not think about that, but that is a reasonable approach.
Thanks so much for our audience for that great feedback. So moving on to our thoughts about malpositioning. So this is when the tube is positioned either too anteriorly or too posteriorly. So we start out with a case of a 55-year-old man presenting with blurry vision in the left eye for the past 4 months. The patient had omet tube in the right eye, 2 omet tube in the left eye, and patient's on Combigam, prednisolone, and there's significant corneal edema seen on exam. And here we can see that the tube is 4.5 millimeter post from the limbus. And so this superior nasal tube is placed too anteriorly. So some of the common problem encountered when the tube is malpositioned is eyes chafing, vitreous incarceration, and corneal decompensation. The management, kind of wondering, our panelist here for this particular case, what are your thoughts about what to do next?
What are your thoughts, Samir? You have an anterior place tube. How would you go about managing this?
You know, for me, if I'm going back to the OR, and obviously there's a surgical problem, I really try to see if I can reposition in the sulcus if they're pseudophakic. And if they're not, then I really try to externalize the tube and reroute it closer to 12 o'clock, just hoping the anatomy is better. And I started to do scleral tunnels. And it's kind of a neat technique, this Albus paper where they use 23 gauge. So you have kind of like an intrascleral pass. And then you have your repositioning under a flap. And then on top of that, use a pericardium or a sclera or cornea patch. So it's almost like a double patch. You know, just to avoid the issues of potential erosion.
Okay, Sarah, what happened?
Yeah, so this patient underwent a vitrectomy. The superior temporal tube was repositioned pars plana, and the superior nasal tube had an explant followed by an infratemporal bare belt implant to control for the pressure in the pars plana space.
I'll make one quick comment. This tube may not have been put in incorrectly. Tubes migrate over time. I've had several patients that have gotten into car accidents, a couple that rub their eyes vigorously and they actually can move their tubes more anteriorly. As you watch them through the years, their tubes are just creeping into the anterior chamber. The whole plate is moving anterior. So the tubes are sitting on the eye and they're free floating in the aqueous. And so they're not actually affixed anywhere. They're just free floating in the capsule. So it may have just migrated anteriorly over time.
Thanks so much, Dr. Chawla. Yeah, I agree. I recall a case that we had together where there was PAS that also moved the tube forward, caused it to touch the cornea. And when that membrane was removed, the tube kind of settled back down. So for this patient, the post-op week 1, the patient did well. The corneal edema was significantly improved. And you know, there's consideration for corneal consult in the future if there's any signs of corneal decompensation or no lack of improvement. Here's a table summarizing the positions of the tube placement as well as rates of the corneal edema, and it's compiled by one of our previous fellow, Dr. An Lee, who's now faculty at Cove. And it's very interesting because the anterior chamber rates for corneal decompensation in native cornea is 7 to 27%. In a previous patient with previous KP is up to 52%. Pars plana, 15 to 29%, and up to 59% in a previous PK patient. The authors thought that the reason why pars plana tube can still have a high rate of corneal decompensation could be a prolonged surgery time needing for vitrectomy for the pars plana tube replacement, and also that these patients have to have kind of poor prognostic eye, kind of more ocular comorbidity to start out with.
I mean, that's very interesting, isn't it? I mean,
Yeah.
going back, Sarah, to the previous slide, we strive to get the tubes further and further away from the cornea. I don't think my corneal decompensation rate is that high with my pars plana tubes, but I want to introduce everyone to Terry Kim. Terry is the chief of cornea at Duke and the president of the American Society of Cataract and Refractive Surgery. And I've asked Terry to kind of chime in on some of these complex corneal issues. Welcome, Terry.
Hey, good morning, Leon. And I want to thank you and your colleagues for the invitation this morning. And I just want to say I'm proud to see that you guys care about the cornea, because retina would never invite me to speak about taking care of the cornea and retina cases. So I appreciate you guys looking out for the cornea. And before I start, I just want to share my words of sadness and sympathy for the loss of Alan Crandall. You know, as many of us know, he was a talented surgeon and a passionate educator, and has taught us all so much. He was a good friend, close friend and colleague of mine and of ASCRS, a former president. So we really mourn his loss, and I know many of us are going to miss him.
What are your thoughts, Terry, about tube placement in front of the iris, sulcus. I guess you would argue that get it as far away from the cornea as possible as well.
Absolutely. That data on the pars plana tube is interesting. I mean, you know, I don't think we've done any kind of formal analysis of this issue, but we certainly have had our share of cases of patients that have corneal decompensation related to their tube shunts. And fortunate to have a glaucoma service that works so closely with us, because, you know, that's important. We create glaucoma problems, you guys create cornea problems, so it's good to have that relationship. I've always thought that, you know, proximity has made a difference, because certainly what we do whenever we go in for a combined case, for instance, is we trim the tube. And in general, we take care of that ourselves. And the idea being getting the tip of that tube away from the cornea will hopefully help prevent that corneal decompensation. But the other thing that I do think makes a difference is movement, any kind of dynamic movement in the anterior chamber. And I cite that because, you know, we were doing some studies using anterior segment OCT, high definition or high resolution anterior segment OCT that Anthony Kuo was working on an investigative unit at the Eye Center. So Priya Gupta and I did a study looking at just the dynamic wound morphology of corneal wounds after cataract surgery. And it was interesting to me how much the wound changed even with blinking of the eye. But I bring this up because we had quite a few patients who had tube shunts who were examined in this study. And these were not patients who had, you know, DSEC or DMEC. These were just patients who had cataract surgery and happened to have a tube shunt. But when we're investigating these patients, it was amazing to me how much that tube moved, even with just the blink of the eye or minimal manipulation of the finger on the eyelid. So I think this is definitely another factor. So in other words, you know, I've seen tubes that are away from the corneal endothelium, lying, you know, in the same plane as the iris, still cause corneal decompensation. I think it's because these tubes move, you know. So that's one factor. And then I also wonder, you know, sometimes I'll trim them and maybe they're opposed to the cornea and physically the tube tip is away from the endothelium. But I would suspect that the movement of flow, aqueous humor flow through that tube is also causing some endothelial trauma.
So you mentioned trimming the tube.
Yeah.
So sometimes you guys trim them too short.
Yeah.
And they end up clogged with PAS, and then we have to go back in. What are you looking for when as the final outcome when you trim your tubes?
Well, you know, I want to get it away from the edge of the graft. And typically we do an 8mm DSEC or DMEC in these cases. So I try not to go all the way out to the perimeter or the angle where I can't see it. And I also try to bevel it, you know, when I make that incision. And, you know, anyone who's trimmed these tubes knows that they're very slippery. So typically my approach is, I love, you know, Ike's MST instrument set that we use a lot for IOL exchanges and for tube trimming, because you do have to go in, and I typically grab the tip of the tube opening with MST forceps, and I'll take the MST, the smaller scissors, not the IOL exchange scissors, and you do have to push, and I try to angle it so I kind of have a little bevel to that tube. And I try to do it just so it's away from the 8mm diameter, which we typically mark with a gentian violet marker when we do our DSEC and DMEC. But you're right. Sometimes, you know, if you have a small cornea, you know, which is obviously a bigger issue, you're having to do a little larger graft, and you may be up against the periphery of the cornea where you may have to trim that tube fairly short. So I agree with you. That probably does happen. We don't hear about it as much because you guys are nice about it, but certainly we can make a better effort to trim them a little less short.
Samir has a question for you, Terry.
Oh,
Hey, Terry. Nice to hear your voice.
Yeah, likewise.
Sulcus tubes, do you have a sense that you're doing less DSECs in those patients? Or, you know, what are your thoughts on that? Because there's really no studies showing.
Exactly.
Sense.
And I think that's a great point, Samir, something we should look at, because just by gestalt, I would say yes, less DSEC, DMEC in patients who have tubes in the sulcus that are behind the iris. So I do think that there's some protection of the tube against the endothelium with that placement? Because have I done it? Sure, but there are probably other factors that precipitated corneal decompensation in those cases. So I personally think that makes a difference, and it would be an interesting thing to look at.
Dr. Shavens might have a comment or question as well.
Yeah, Keith Barton and the folks at Moorfields looked at native corneas and presented at AGS this year on not only the position in the AC, but the position of tube entry and the angle and its importance. Yeah. And he found that, you know, at 5 years, we were losing 37% of endothelial cell density centrally and 50% in the quadrant where the tube was, if that insertion was 50% above Schwalbe's line or involved Schwalbe's line. So it's actually probably the angle of entry that we have. And then the interesting thing I thought about, you know, with your comments, Dr. Kim, about, you know, trimming the tube so it doesn't touch your DSEC or patch. In the case of a native cornea, they actually found greater endothelial cell losses with a short tube length in that study at 5 years. So that was just an interesting discrepancy between grafted corneas and native corneas.
Yeah, that's interesting, Shane. I was thinking about this a few minutes ago, and you know, your comment about your angle of entry, I think that's an insightful one, because if you think about, for us as corneal specialists, we certainly have a lot of things that cause endothelial cell damage and endothelial cell loss, and you know, some of them are, you know, iatrogenic. You know, when we put in an anterior chamber intraocular lens, we know that there's probably going to be endothelial cell loss. You know, there was a phakic IOL that was in clinical trials in the United States, and it was stopped because of endothelial cell loss. And I think what's interesting about that phenomenon is I think it has to deal with movement of that prosthetic device, whether it's an anterochamber lens or whether it's an anterochamber phakic IOL, that causes that damage to the cornea. And I think it makes it worse, it precipitates it. I also think about other things that may not necessarily be foreign bodies, like a lens fragment. I think all of us have probably had a case, you know, in their lives where there's a retained lens fragment. And in my experience, and this, we published on this in an article in AJO in 2016, that a high percentage of these patients with retained lens fragments go on to DSEC or DMEC or corneal decompensation, and it's typically related to that inferior quadrant where that lens fragment is probably moving around and bouncing against the endothelium. So I do think that the location of entry is also probably a factor, not only the actually tube tip bouncing in the endothelium, but the irritation and the trauma that's occurring right at the site of entry.
Along those lines, one of our participants is wondering, any thoughts about corneal decompensation being secondary to altered aqueous flow dynamics in addition to the mechanical effects of the tube?
Yeah, I mean, that would go along with Shane's comments about how shorter tubes and native corneas may have greater endothelial cell loss. It may have something to do with the altered aqueous humor dynamics going through that tube shunt. So I think there's probably multiple mechanisms of action that cause endothelial cell loss related to tube shunts.
And then any thoughts on if you think the rates of corneal decompensation are more common in transscleral CPC? That's a common alternative that we use instead of tubes in these really severe end stage cases.
You know, I haven't particularly looked at that in specific, because typically a lot of these patients who have had that procedure have also had other procedures done. So it would be hard for me to say if that in and of itself is a factor. I would have to answer, you know, probably not convinced based on what I've seen. But again, no formal study looking at that factor alone, because typically these patients have had other glaucoma procedures done that have probably already caused an insult to the cornea.
Okay, this is a glaucoma webinar. Let's go ahead and proceed. Terry, we'll get back to you in just a little bit.
Okay.
Sarah?
Yeah, thanks so much, Dr. Kim. So our next topic is about tube erosions. Number of risk factors has been associated with tube erosions, including number of previous surgeries, scleral patch graft use, erosions, minimal tunneling, eyelid inflammation, female gender, Caucasian, use of anti-VEGF, and older gender. So Dr. Mir and team has found that women was twice more likely to experience tube exposure than men, dependent of age, as well as white race was also a risk factor. Dr. Ahmed and his team also found that there is an increase with the number of previous surgeries in terms of increase in the odds of exposure, and that risk was, the odds increase was found to be about 1.29. Also older age, female gender was also risk factors, and protective factor was use of a scleral patch graft. Here, Dr. Liu and team found that the average number of the patients receiving anti-VEGF injections for AMD was more likely to experience multiple tube erosions. And she did this as a retrospective study, looking at patients who received anti-VEGF with those without anti-VEGF. And patients with tube erosions were typically receiving chronic and recurrent anti-VEGF injection as well. This is Dr. Herndon and team regards to the TVT study. 5 out of the 107 patients in tube group experienced tube erosion, and one of the patients had endophthalmitis associated with this. This transitions us to the tube endophthalmitis.
Before you go any further, Sarah, let's stop there. So Julia, how do you handle a tube erosion? What's your next patch graft material that you use?
So it depends a little bit on the erosion and the situation. Typically they are kind of an indolent thing that happens slowly from the eyelid and everything. And so if it's that, a situation where I think it's likely to, that situation that caused it is going to continue to be there for the long term, then I'll pretty much go in and move the tube, reroute it and recover it, trying to make, again, a long tunnel to prevent it from, getting exposed again. If the erosion is because of something that, the patient, hit their eye with, some device or something where it seems like, the incident that caused it is not a long-term thing, then I think just going in and kind of tucking in a new patch graft and then recovering it, might be reasonable. But typically, when I just go in and recover it, it's going to get exposed again. That I'll just plan on going and rerouting it initially now.
Okay, Sarah, thank you.
Yeah, thank you so much, Dr. Rosedal. As you're mentioning, associated tube plate or patch exposure has been associated with tube endophthalmitis, as well as immunosuppression and a history of PK as well. These could be delayed up to 31 months. That's been reported in literature. Dr. Ong Lee has looked at the Duke and Co cohort and found that the exposed location was most frequent in the superior temporal quadrant, and these patients had all received intravitreal antibiotic for management, and some had also received topical fortified and some intravitreal dexamethasone. So in summary, regarding the management of tube endophthalmitis, tube exposure, like Dr. Rosenthal was mentioning, was a necessary risk factor for late onset endophthalmitis. If no exposure and no conjury, consider other causes, such as a steroid inflammation or prior trab. However, tube repair revision is very important to control the infection and prevent recurrence ultimately, and the timing depending on individual case. Endophthalmitis during the immediate post-operative period, but these organisms you should consider might have been introduced during the time of surgery and might not be associated with device exposure.
We had a couple questions about tube erosions. Do we think erosions were more common superiotemporally than other sites simply because superiotemporal is the most common site for placement? And related to that, how do the rates of tube erosion in the various locations relate to frequency of tubes placed in each location?
Samir, what are your thoughts there?
So, there have been, I think, 2 studies that suggested, I think Alan Beck's group and Emory suggested that inferior tubes had more exposure risk, but it wasn't statistically significant. and they didn't comment on which tubes. My feeling is Ahmed's inferiorly. I really like to tunnel those, put them under host sclera, because I am concerned that they may have more risk of exposure. That's just my, I mean, thankfully it doesn't happen a lot, but when it does, I think Ahmed's tend to have a little more risk. But I really don't think, if you do a nice job with your inferior placement, a cornea we already alluded to, that there may be some wound dehiscence. But I used to do inferior temporal when I was a Duke fellow. I think that's how it was. Leon, I don't know if you're still doing that, but I do inferior nasals, typical non-valve devices, and they do well. I think they do well.
I mean, comment that paper by Dr. Lee was reported only the number of occurrences. It wasn't it was a cross-sectional view, so it was a retrospective study. So it wasn't stating that that's the most likely quadrant to expose. It was just simply stating that's the most common one that was seen retrospectively. But that was because there's more tubes placed there than elsewhere. But yeah, the data suggests that maybe inferior tubes may have a slightly higher risk of exposure, but there's not very strong data for that either.
Dr. Howard wonders if a lot of us try and snake our tubes to 12 o'clock, if we did the same to 6 o'clock, if that would be helpful.
Yeah, that's what I always do that. I try to put as close to 6 and 12 as I can get them.
Same here.
Okay, now we have 10 different cases that we'll highlight that hammer the point on several of these management issues. So Sarah, let's go through the first case.
Yeah, thanks. So this is a 71-year-old gentleman with mild plaque in the right, severe plaque in the left eye. He's had express trab in the left followed by a revision, and he's subsequently received a phaco Bearbout tube 350 in that left eye, and there's continued evidence of progression. He subsequently received an inferior nasal Ahmed ClearPath 350 to the sulcus in the left eye here. Post-op month 4. This is the external photograph of the patient's eye. He reports seeing the diagonal line in the central vision, and this seems to be caused by the tube, given the tip of the tube to the pupil edge is about 1.6 millimeter.
Shane, let me stop you there, Sarah. So Shane, how often have you had patients notice this tube when it's in the visual axis?
Well, depending on the severity of their visual field loss, they often don't. But I've had to trim a tube that looks similar to this. Unfortunately, in this case, your tube's probably going through the superior visual field. On your visual field test, the patient had lost their inferior field at an altitudinal defect. So they're probably more sensitive in that superior field. And yeah, I have had to trim these.
Go back, Sarah, to the field. I didn't think about that, Shane. Okay. So maybe the hemifield affected does. So the point is, I tend to like to keep my tubes long so you can see them in the visual axis. And I've had 2 or 3 patients over my career who have complained of a diagonal line. 2 of them I trimmed and they didn't notice any difference. But we'll see what happens with this case.
I've only had one, Leon, and she had noticed immediate relief from the trim. So, but it's pretty uncommon for them to be bothered by it, interestingly.
It's usually the referring providers that are more bothered. The optoms always are more bothered than the patient.
Go back, Sarah, one second. So one thing I did, I measured at the slit lamp 1.6 millimeters from the tip of this to the pupil edge because I didn't want to trim it too short and keep a bevel up with fear that it may block. So you'll see what happened in the video. And we could have used the same technique we described several years ago with the ab interno revision, but that would not have been able to maintain a bevel. And that technique, the tube is just cut and there's no bevel. And Terry Kim mentioned how important it is to bevel these. So we pulled the tube out and the thought was, let's cut at 1.6 millimeters, bevel up. And you got to go through a lot of different approaches in your mind about how to to make sure it's a correct bevel. You're kind of upside down, and in this case, 1.6 millimeters back, we tried to trim it so that it was bevel up. Again, mind you, it's still in the sulcus. I could have repositioned it to in front of the iris, but I like the idea of keeping it further away from the cornea. So we place it back, and I'm still not happy with that. And it's sort of beveled to the side. So we pulled out again and made sure we're going to switch over to a bevel down. So the iris does come, the pupil does come down over it, then it should not block the outflow. So I get a nice bevel down, cut, and we reposit it, and it I feel much more comfortable about that. So when the pupil comes down, it's the edge of the tip of the tube. So I close with Restore sealant. Okay, Sarah?
Restore back. Okay. And the patient has done really well in the post-operative course with a resolution, a diagonal line, and her vision. His vision.
Are there any questions, Joanne, before we go to case 2?
Yeah, if we backtrack a little, we had a couple about management of tubes and endophthalmitis. I was looking, I'm not sure that we have a case on this later, so probably a good time to just go ahead and address these. If a patient develops endophthalmitis, would anyone remove the entire drainage device? Similarly, if a patient with a Boston K-Pro and a Barvelt in the pars plana develops endophthalmitis, do you do something about the Barvelt during the vitrectomy or leave it if the blood looks healthy? So one is just, would you take the device out? And the second is if it's in the case of a Boston K-Pro situation.
It depends. We use that response a lot, don't we? Charlotte, when would you take the whole hardware out?
Yeah, this is something we've discussed over and over and over again between us and our retina colleagues back and forth. If the tube looks like it's infected, then obviously it has to come out. If you see any purulent material around the tube, tube exposure area, or the plate itself, that it really should come out. But a lot of times when you have more than one hardware in the eye, it's hard to figure out which one of the hardware caused the original infection. But if it looks like the tube is very quiet and the bleb is very quiet, I've been leaving them in and then just simply requesting that if I'm not there or someone else whoever's doing the surgery, to go ahead and just make sure they irrigate antibiotics around the capsule area.
What's your approach, Samir?
So, I'm assuming they've had intravitreal antibiotics. I like oral quinolones like moxifloxacin. And if the tube itself is just the issue, but the plate seems sound, I will try to leave it in. But if there's any exposed plate or close to the two plate junction, then I think you just have to take it out. There's really no way to salvage a plate exposure. So it really depends how virulent the infection is, but these can be tough cases.
So along that vein, if you,
go ahead, Joey.
Sorry. No, why don't we do the K-Pro part first? And there was a follow-up question on once you've taken out the drainage implant, how long do you wait to put in the next implant if you have a pressure spike?
What was the K-Pro question?
I think it was similar. It was, would you leave it in place at the time of vitrectomy if the bleb looked okay? So I think we kind of addressed that already.
Okay.
So now the question is, you've taken out the glaucoma drainage device because of endophthalmitis, the pressure spikes, how long do you wait before putting more hardware back in?
Once the inflammation infection is cleared, obviously you have to tell the patient you're going to remove the device and the pressure is going to go back up and you likely will have to revisit this. So I'm probably going back 2-3 weeks out. Okay, let's go to the next case.
All right, so we have a case of a 44-year-old woman with severe chronic angle closure in the left eye here. The patient had a trabeculectomy in the left eye with needling. There was continued progression of glaucoma in this left eye, and she subsequently had a ClearPath 350 in the left eye with excellent pressure. But post-op week 6, there's a long tube that's near the cornea. There's some mild defaults seen centrally with corneal edema. And there was a decline in the vision as well. And those are our visual fields.
Yeah. Do we have data on her corneal thickness at this time?
It's going to be coming up. I think it's
Okay.
like a consumption range.
Yeah. So corneal edema, we're fairly have fairly recent tube surgery. What does a panelist do as far as repositioning, or do we start talking to our cornea colleagues? Shane?
I think at this point it's always reasonable to get cornea involved to find out if tube reposition into the sulcus in the pseudophakic patient would be enough, or if they feel like based on exam and progression of CCTs with the complex and multiple surgeries she's had in the side that she may need a combined procedure. In our case, I have a cornea specialist that is comfortable doing DSECs while I reposition a tube to the sulcus. So we can sometimes, if they do need a transplant, get both done at once. So I would at least get them involved at this point. Many times, though, the reposition is enough, and these corneas can recover. So,
Sarah, let's see what happened.
Yeah, thanks. And this, here's the video. And just getting back, the CCT for this patient was 729, and that will be shown in the next slide.
So we're going to take an approach of externalizing the tube. I like to do a keratome incision right down to the tube. It's not a tunnel incision, mind you. It's a incision goes straight down. Viscoelastic has been placed. What's nice about this technique is that you can continue to maintain a nice bevel. Again, her cornea over 700, so it wasn't clear if we were going to be able to recover her cornea, but I think it's important to move fairly quickly when you start seeing corneal edema even over the tube. And then we close her with her short. So let's see how she did, Sarah.
Mm-hmm. Okay, so on post-op month 1, she actually did remarkably well. There was an improvement of visual acuity to 20/30 from 2200. Resolution of the corneal edema, and her CCT on post-op month 4 was 590, so she recovered quite nicely.
Yeah, this is a picture from the iPhone just a couple of days ago, showing nice clearing. So Terry, I think you're still on the line. What is your approach? I mean, if you got my thinking and my teaching is that if the cornea is greater than 700 microns, then it's pretty much toast.
No, I think one of the lessons we've learned is not to go by the absolute corneal thickness number, Leon. And one of the things I've learned from doing refractive surgery is you can have a 450 Pachy and a 650 Pachy that are all normal. So we know that the corneal pachymetry ranges from person to person and totally physiologic, totally normal. So I wouldn't go with an absolute number. I think what's more important is following the patient for serial pachymetries. If you have an opportunity to do endothelial specular microscopy, that could be helpful to see what your cell counts are. Sometimes it's difficult if you have corneal edema to actually get cell counts, but if you're able to get them, that could be helpful too. But you know, in cases like this, you obviously saw progressive corneal edema in this patient, and I think it was the right move. Also, though, I mean, I do think that's reasonable, depending on, again, the other factors of the patient. You know, what their visual acuity is, what their other eye health is, if they have any other predisposing issues for their cornea health. To watch them, treat them with steroids. And I had a question for you guys is, I mean, is there a role for ROCK inhibitors in these kind of scenarios? Have any of you used ROCK inhibitors? Just curious, you know, Debakar Gupta and our cornea group with Ellis Wisely just published our series of, you know, the reticular epithelial cell edema with Repressa use and AJO, but I'm just wondering, is there a role for something like that here? Because, you know, our transplantation techniques are going to evolve. As Shane mentioned, you know, I feel comfortable, Leon, we've done this doing a combination approach. I feel very comfortable doing a DSEC combined with whatever tube manipulation you're going to do, whether it's moving it to the pars plana or the sulcus. However, as you know, I like to do the DSEC afterwards at the end, because if you have any manipulation of the cornea or particularly, you know, when you decrease the pressure in the eye, there's a high risk for that DSEC graft detaching. So I like to go at the end. But I was just curious from the panelist's perspective, is there other medical treatments that are possible? Because one of the things that is evolving and developing in the cornea field is we are looking at endothelial cell transplantation. And this is a procedure that Dr. Shigeru Kinoshita has pretty much pioneered in Japan, and his clinical trial data looks pretty good. So CorneaGen will be taking this for clinical trials and evaluating this as a modality for rejuvenating corneal endothelium without having to do a tissue transplant. It'll be a cell transplant therapy. So, you know, the idea of actually having a rejuvenation therapy for this in anticipation for patients who have higher risk for corneal decompensation, whether it be Fuchs dystrophy or patients who have glaucoma with other procedures, trap, tubes, etc.
Shane, you have some comment about the rho-kinase inhibitors?
Yeah, for the rho-kinase inhibitors, at least in my experience and a few case reports out there, one including in JAMA Ophthalmology from fall of 19, there was people with, in the case report, it was a Fuchs dystrophy patient that was treated for glaucoma with rho-kinase inhibitors, and they developed this macrocystic mosaic epithelial edema, which is really interesting and like nothing I'd seen when I had seen it the first time in a patient that I had done a tube on that was probably too anterior. And in her case, her corneal edema worsened quite a bit when we switched her to Repressa, but it was this really beautiful mosaic of epithelial edema that essentially went away, and she had the decimase folds that are more typical of tube contact once we took her back off the rho-kinase, and she did better with a tube reposition to the sulcus. But I don't know if they see it as much in the corneal ward, Dr. Kim, but I tend to be hesitant in adding rho-kinase for my patients with Fuchs or impaired endothelial function, just because of those case reports. Whether or not that's right, I'm not sure.
Well, I just have a case series in hand of patients who have had corneal insult from various etiologies. We had a case of TAS. We also have had cases of traumatic DSEC-DMEC, and we've actually used Repressa successfully. And you know, that's one of the things we observed temporarily was that the interesting reticular and epithelial edema pattern that you see. And typically we used the therapy for about a month or two, then discontinued, and you would see that reticular edema go away, and then actually their corneal edema improve. So I wouldn't say it's, and I haven't actually, I don't know if it's been used. I haven't paid attention to see if some of your patients who come in with corneal edema related to tube shunts on Repressa just for IOP management to see if that does anything to their endothelial health. It was just something that I was wondering if you guys were utilizing.
Okay, Sarah.
Okay. Thanks. So next we move on to a related case.
Go quickly through this one. This is a similar case. Just skip forward to the video, Sarah.
Yes.
So the young patient, the common thing for both of these patients was a ClearPath device. And as I mentioned at the last webinar, the previous form of the ClearPath had a curve, anterior curve, that New World Medical has now replaced with new packaging. But same type of technique, make a vertical incision right towards the tube at the viscoelastics place, and trim it shorter, bevel up, and she's done very well.
Mm-hmm. Yeah.
I will tell you, Leon, when you trim those, I can see how you can. We try to make a bevel, but as you noted, it's difficult to do with an Ab-Interno technique.
Right. That's exactly. And last case for you, Terry. This is a real quick corneal decompensation. Then we'll let you enjoy your daughter's 16th birthday.
81-year-old gentleman with severe plaque in the left eye here, presenting with hand motion, vision, IOP at the 30. Patient was unfortunately lost to follow-up and received an OMIT in the left eye elsewhere. When the patient came back to us, there was significant corneal tube touch seen in the left eye. And there was also corneal edema with neovascularization, and the photo of our image is displayed here. The vision was light perception at this point. IOP was 23 and corneal thickness is 776. Multiple providers has discussed with patient regarding a nucleation. So And then the visual field presented here was the other eye. So at this point, what are the panel's thoughts about what to do next?
Yeah, so this is a guy who was having pain in this left eye, light perception vision. Other providers that said, just take the eye out. You should be comfortable then. But he really wanted to save the eye, and he had an eye med that was banging up against the cornea. So I had him see one of my cornea colleagues, and we'll see what we did. Yeah, so the cornea colleague wanted to stage the procedures. He felt that we should reposition the tube first, and then he's going to go back later to do a DSEC procedure. So with these procedures, again, this IMED was placed a year or two ago on the outside. And when you open these tubes, there's always a little sleeve of tissue over the tube. So you have to open the tube and to get this tube visible, open the sheath over it. And now once you have that, you can pull the tube out and then reposition it as you see fit. Many of these cases, in this case in particular, the visualization in the anterior chamber is very poor. So you'll find that a lot of these procedures are just a feel type procedure. And based on the bevel of the 22 gauge needle that I used being 3 millimeters in length, we use that bevel to help guide my placement. Here you see, so the bevel is 3 millimeters, and I'm teaching, well, go into, you are halfway between the inner and outer bevel, and that's when you're going to start turning your wrist down to be parallel with the iris. So in many cases I use these parameters when you can't really visualize in the anterior chamber. So what we're doing is replacing this more towards 12 o'clock, and this will be the first stage of the procedure. Samir, you have some comment on these techniques?
So in the Middle East, with these congenital glaucoma cases, those corneas are just opaque. And obviously, you have tube repositioning issues. So a couple tricks that we've come up with: if you get a 30 gauge needle, fill up the AC with air. And what's nice is you sometimes get that fish egg approach, and you can actually get a contrast and get a sense of different tissue plane. So before you reposition like you did with the 23, get a 30 gauge just to see where you are in relationship to those air bubbles. Are you too posterior, too anterior? You can always pull out the 30 gauge. And then once you're happy with the trajectory, then you go in with a 23 gauge at that same plane. So that's really helpful. And then using a light pipe, we presented this at Moorfields actually 2019, where you turn out the room lights because you get a lot of scatter with the OR microscope. And at the limbus, you use a retinal light pipe to transilluminate. You can actually see a lot of detail in the anterior chamber that you can't otherwise see. And I think, Terry, maybe you've seen this with some capsule stain with cloudy corneas. I learned this from one of the Saudis when they were doing a phaco, and I saw the room lights out. I said, what's going on here? And they had a lot of corneal opacities, a lot of reflex from the OR lights. They turn out the lights, use that light pipe at the limbus, and you could actually do the capsular rhexis under that transillumination. And that's, so it's a nice little trick. Waiting to publish that transillumination thing,
Yeah. Terry, what's your approach to these cases? You and Shane mentioned many times you'll do combo procedures, but your colleague thought that a DSEC, not a PK, a DSEC would be good for the main issue is pain control in this case.
Yeah. Well, for us, we'd always prefer to do a posterior lamellar transplant as opposed to a full thickness transplant. That's for sure. And even in this kind of case where you're trying to obviously make the patient comfortable, it's not a visual issue. So even if they do have, this patient had corneal neovascularization, probably had corneal scarring, even though your view may be difficult, if you can get away with a DSEC to treat their bullous keratopathy, a much better way to go. So as you said, Leon, I don't mind doing these in combination together, and typically like to go last. The visualization is typically difficult, but probably okay enough to do a DSEC, which requires less visualization than a DMEC. I am now doing actually DMEX in patients post tube and post trab, and our results have been pretty successful. But for these kind of cases, we'll do a DSEK as the visualizations a little better, and sometimes we may require scraping of the epithelium. Samir, you mentioned the light pipe. I certainly have used that in doing capsulotomy in patients who have corneal scarring, and it's difficult to see. It's a great technique. And actually, some folks in Korea are developing some endo-illumination instruments on the phaco tip, so you can actually do that instead of using the coaxial illumination from the scope with some impressive visualization. So I think that's going to improve things as well. So in this kind of scenario, what's nice is typically we have a nice S stamp that's clearly visible, usually even through an opaque cornea. We oftentimes use an air bubble technique to make sure we've scored enough of the Descemet's membrane off to make sure we have good apposition of the DSEK tissue against stromal tissue to have good adherence. So I think it's very reasonable to always start with this approach. And if you can't get it, you can always come back and do a full thickness PK if needed.
All right, Terry, we're going to let you go. Thanks so much for your comments.
Yeah, Leon, it's a pleasure to be here. Just to reciprocate, you guys are respecting the cornea. I want to let you know that I teach all my fellows to respect glaucoma too. And we do a lot of finger tension once in a while, to check pressures.
When's the last time you looked at a nerve, Terry?
Oh, what is that? You mean optic nerve?
All right, we'll see
I think
you, man.
I know. Well, I'm just going to let you know when we do it, we always calibrate the finger between finger tensions just to make sure it's accurate, Leon. That's how we respect glaucoma.
We
All right.
appreciate that. Thank you.
Okay. Hey, congratulations on your glaucoma series and have a good, successful meeting.
All right, thanks. All right, Sarah.
Dr. Herndon, quick question. Someone was wondering what was the actual blade you used to cut the tissue around the tube. It didn't look quite like a super sharp.
Yeah, it's I don't know the manufacturer. It's a super sharp blade is all I asked for. It's a guarded blade, so you have to make sure that you place it back in the guard. But it's an extremely sharp blade. We could find the manufacturer maybe before the call is over.
Yeah, I don't think that it's the same super sharp that everyone else would get if they asked for that. It's a special.
So it's a Herndon. It's a Herndon super sharp.
It's a Herndon super sharp.
I'll find out who the company is.
It's a 15-degree blade.
All right.
Thanks. Our next case here is a patient with MVG. The left eye underwent an omit with post-op day 1, hyphema, fibrin, elevated pressure. To decrease the pressure, the wound was burped at the para, Diamox and topical eye drops were used. However, there was rebleed and pressure increased up to 74. The patient was taken to the OR for AC washout clot removal and TBC. So this is a very interesting video that we'll show right here.
Pratap, I think this is your case.
Yeah, so I actually like to use the micro scissors, whether the MSTs, but these are the retina micro scissors to cut the clot out, because I don't like to pull on the clot because then it can rebleed. And so then after that, here you can see the fibrin was in the tube, so I just went in with the micro graspers and got to pull the fibrin out. And you can see there's a big giant fibrin clot there. And now the tube started functioning well. You can see here we're going to inject it and it'll get a bleb that's going to pop up. If it didn't, then I would go back, open up the conj, go through the capsule and go back to the valve mechanism and take the residual clot material out of the valve mechanism. But here it came out and the bleb came up nicely, so didn't have to go open the conj.
That's pretty impressive.
Yeah, the patient did very well with pressure of 19 on post-op week 1. So this is our 5th case here. This is a 56-year-old woman with mixed mechanism glaucoma, severe PDR. Both eyes was emulsified silicone oil as well. The patient had an infranasal OMED clear path 350. There was an exposed ripcord on week 3 that was removed. However, there was dehiscence of conj inferiorly on post-op month 1. The AC was shallow and the lumen was partially plugged with iris. The pressure was low. Vision hand motion. At this point, what are everyone's thoughts about what to do next?
Sure. How do you manage these patients with Now I did use cornea material, but it was actually the hiss right over one. Those of you who have used the clear paths know that the foot plates are more anterior, which makes it easier to place the positioning sutures. But now when those foot plates is exposed, what is your thought, Stuart, at this point, what you would do next?
So if you're 1 month out, I hope the capsule is formed enough that you could potentially trim back that area of the foot plate that was exposed. If you couldn't completely trim it, you might try maybe beveling it somehow to get it to be lower profile. But that sounds a little technically challenging. Yeah, I would probably just excise that foot plate and then just sew it directly to the sclera underneath.
So don't have to take the whole device out.
Right.
Okay, Sarah?
Yeah, that's exactly what you did here. There's a truncation of the exposed area.
Yeah, so those of you who don't know again, this is, you can see the 2 foot plates of the ClearPath 350 in this case, inferior nasal quadrant, left eye. So I figured that if we just trimmed that anterior exposure, then we should be okay. Of course, you prepare the patient for the fact that we may need to take the whole device out. Certainly if it were more posterior, if the plate were exposed, then we were probably talking about taking the device out. But this was a slick 10-minute procedure, and I felt good about it until I didn't.
Right. Yeah, so unfortunately the patient had the second wing of the clear path exposed on post-op week 2. It's occurred.
Yeah, so now the second wing of the foot plate is exposed. Do you think about taking the device out now, Stuart?
Well, how did the repair go for the first foot plate? Is that still intact
Let's look and see.
at this point? Because if it is, you could just do the same thing on the other.
Yeah.
Sarah, what was the time of exposure? Like how long was the foot plate exposed?
Fairly quickly. So let me just go back here.
It was about a month out. The ripcord was exposed, and so the ripcord was pulled at 3 weeks, and then a month later is when she comes back with this spoon.
Yeah, the biggest thing I worry about is epithelium growing down under the conge, starting to try to work its way back. So whenever I repair the tubes the plates that are exposed, I try to go in there and at least check with a little cautery to see whether conge has grown down underneath. And sometimes I just excise all that tissue out there just to make sure it hasn't. But this I mean, this is kind of a intermediate length exposure, so maybe there's not much conge down there.
Right.
Or epithelium.
So roll the video. So now the other foot plate's exposed, and she claims she wasn't rubbing her eye or anything. So we decided to do the same technique. And to your point, Stuart, the other side, the original side, is exposed again. And you can see that where I trim, I probably didn't trim enough. So I did do cautery. It's not shown in this video. I didn't have a sense that there was any epithelium growing down. But we trimmed both sides, did another horizontal mattress atovicral on the BV. And at the end of the case, she looks great. So we closed both sides.
Would you consider maybe a small patch graft over that excision site, just to get the conge a little more
little cushion
scaffolding? Yeah.
Yeah, I consider it. Sarah, go back to the last part of the video. I want to show how good it looked at the very end. Yeah, so again, well covered. I did consider placing a little patch graft cushion there, but I was real pleased with the way it looked here. And so let's see how she did.
She did remarkably well. There was on post-op week 3, all the wounds were closed. The plate was well covered, and there's no additional area exposure.
Again, we're 3 weeks out, just our last week, so we'll see.
Mm-hmm. Okay, I'm going to turn over now to Dr. Liu, for my colleague, to take over.
All right, James.
All right, next we'll have a case requiring an implant exchange. So this was a 65-year-old with severe POAG seen over several years. His past surgical history is notable for a phaco eye stent in the right eye that had uncontrolled post-operative pressures requiring an urgent Ahmed valve to be placed. This was later followed up with a Baerveldt implant. His left eye is the one we'll focus on. The surgeon jumped to a phaco Ahmed in light of what happened to the right eye. But this too did not provide enough IOP control, and he later got an inferonasal Baerveldt implant there too. So he presented to us with IOP in the mid-20s and progression on his visual fields. Here's what it looked like at the slit lamp photo. This was the one that was shown earlier with two tubes kind of encroaching on the visual axis.
Again, you see my my approach to having these long tubes. He unfortunately did not complain of a visual disturbance.
Here's his OCT and the corresponding visual fields. This in 2013, 2014, and then 2018. So at this point, what would be our next steps?
Shane, so he's got two tubes in the left eye. In fact, both eyes are getting worse, and we'll talk about the right eye briefly, but you have an Ahmed up top and a inferior nasal Baerveldt 350 below in the left eye. Pressures in the mid-20s now. What's your approach?
You have a couple options. I mean, you could still potentially place a smaller tube shunt in the supranasal area, but I would probably tend to, this patient doesn't have a history of uveitis, correct?
Correct.
Okay, I would tend to consider doing a cycloablative procedure, either a micropulse or ECP combined with a needling of the blebs over the plates, and either 5-FU or mitomycin C, depending on how robust his capsules are over the plates at the same time. There's not a lot of data to guide us as we get further into these cases when you're doing third and fourth procedures. But I think with he basically has dual exhaust in both eyes at this juncture, and by doing a process to reduce aqueous production, I think that tends to be a pretty powerful 1-2 combo for these tough cases.
Okay, James.
So in this case, the decision was made to remove the Ahmed valve and replace it with a Baerveldt. And here is that procedure.
Yeah, so this Ahmed's about 4 or 5 years old, and those of you who do this type of surgery know that you want to form the eye with a viscoelastic before you enter this capsule. And this capsule material is really tough. In fact, many times I'll use that capsule material as a patch graft material. It's so tough, and then you got to be wary, be sure that you know about the positioning holes. There's always a stalk that keeps the plate attached to the sclera, so those need to be cut to allow for removal of the device. And we opened up the capsule, opened up the space superior temporally on top of the capsule, and then placed the Ahmed clear path in the superior temporal quadrant. What's nice about this, if you're happy with the original tube track, you can use it. And we placed the tube through that. My technique of using the venting slicks, and also use 90 nylon wicks. And he did extremely well with this, and in fact had the same procedure in his right eye a few months ago.
Yeah, that's really elegant, Leon. Just a comment, while I was at Duke, I had the great opportunity to watch Sharon Freeman do some cases with tube repositions, and she would actually cut the tube, leaving the old tube within the AC in that tract, and it just makes it easy to find. Once you have your other tube in, you slide that one out and the new one in. But really, I didn't think of the exchange. It's nice.
Yeah.
Dr. Herndon, do you have any tips about having done some of these, when you're taking out that old implant, identifying your landmarks and the extraocular muscles again can be really challenging, and then trying to put a big plate back in, it's easy to get disoriented and not know where exactly it's going.
Yeah, it's tough. You can't hook the muscles now because the rectus muscles are just incorporated in the scar. So you're on top of the muscles. You really take a curved Stevens and open up that space really widely on top of the capsule. And if we're not able to place it completely, then you can trim the edge. You can trim a part of the wing of the plate to allow proper sitting of the device. He's done well. Again, had the same procedure in the right eye. He's single digits now, about a year out in the left eye and maybe 6 months out in the right. And so, yeah, Shane, we did mention cycloablation as an option. And if it goes back up again, then that may be a consideration. There's very little data. We do have some data on third tube versus fourth tube. It seems going from 2 to 3 tubes is helpful, but going from 3 to 4 tubes has not been helpful in our experience with further pressure lowering.
So in this case, he did very well. The exchange occurred sort of late in the game when the implant had sort of started to fibrose down and the capsule was well formed. So I did want to ask if things would be very different if the surgery were to be considered at an earlier time for an earlier exchange. And if our panelists have any thoughts, please chime in. Otherwise, we do have a video demonstrating that early exchange too.
Yes, this video is narrated when the patient had an Ahmed done just 6 weeks prior, a young patient, and had extensive encapsulation, pressures in the 50s. And so we talked to her. Lots of things you can do. You can do a capsulectomy where you cut a little piece of the capsule out and you feel good for about a week until that capsule scars back over. But we thought that we would exchange from a valve device to a smaller barbell 250. So let's roll the video. It's narrated.
This is the left eye of a 53-year-old woman with moderate inflammatory glaucoma, possibly a positive Schlossman component, who had an Ahmed FP7 placed to this eye about 6 weeks prior when the intraocular pressure was 60 millimeters of mercury. It was decided at this point, because of early encapsulation and IOP back up into the 50s despite acetazolamide, to exchange her Ahmed for a barbell. It's important to form the eye with viscoelastic because once you enter that capsule, you'll see quite a bit of efflux of aqueous, and you want that viscoelastic tamponade in the anterior chamber to prevent anterior chamber shallowing. With further dissection, one is able to remove the tube after further viscoelastic is placed into the anterior chamber. And after the anterior dissection, we turn our focus to the Ahmed. The capsule is not very thick, and the Ahmed, as you see, will come out quite easily. There are positioning holes that usually have 3 stalks, but this just has 1 small stalk attached to 1 positioning hole, so this is removed very easily. Further dissection posteriorly reveals a thin capsule, that anterior portion of which is excised. Curved Stevens sternotomy scissors are used to create an adequate pocket in the superior temporal space to accommodate the 250 barbell in this space. The barbell is secured to the sclera with 2 9/0 nylon sutures. And the barbell tube is cut in a long bevel up fashion. Now, I was pleased with the initial placement of the Ahmed tube, so this same track of the previous Ahmed tube can be used as outlined by the previous 9/0 nylon suture, and it slides in quite nicely. I perform a technique of 2 venting slicks and then 2 9/0 nylon wick sutures, and we published our technique in the Journal of Glaucoma recently that shows good early IOP control after these non-valved procedures. Once the wicks are placed, the procedure commences by closing the conjunctiva with 8/0 vicryl suture. The previously placed scleral patch graft was in good shape, as the previous surgery was only about 6 weeks prior. Conjunctiva is closed securely. At the end of the case, we see a well-placed barbell tube in the anterior.
Yeah, so it's early with her, but She's doing great. Pressure 10, post-op day 1. I followed up with her last week. She's still doing well. So we'll see, hopefully. And it's clearly the hypertensive response, in my experience, is greater with the valve devices than with the non-valve devices.
So the decision to exchange the Ahmed for the Baervelt comes from evidence and general consensus that a Baervelt would likely produce a greater IOP reduction. We discussed the differences between the implants in our last webinar. To recap, here are some of the differences between the Ahmed Baervelt comparison studies. In general, again, you can see that the mean IOP and the reliance on medications were both lower in the Baervelt group. But there is still variability, and with low pressure, there is also an increased risk for hypotony. As many of us know, each eye can behave unpredictably. So is there any way to more reliably control the post-operative pressure given some of the variability that we typically see in these tube surgeries? I think someone had mentioned the iWatch, which we'll discuss here. So this is a new product from a Swiss company. It's called the iWatch Glaucoma, adjustable glaucoma drainage device. It's basically an adapter that can be adjusted to titrate the flow in a Baervelt implant. It utilizes a magnetic dial to open or close off a deformable tube within the device, thereby adjusting flow through it. This obviously would help to decrease several complications seen in tube surgery, including early hypotony and later hypertensive phase. It's been approved in Europe for use, but not yet FDA approved. This is from some of the prospective non-comparative study that they conducted. And some of the early data is very encouraging, basically showing an ability to stay within this narrow range of ideal IOP post-operatively. Most of the adjustments need to occur within the first 4 weeks, whereas after that period, little adjustment was necessary. And then this is unpublished data comparing the Ahmed valve to the iWatch plus Baervelt system. The Ahmed valve in these black dots, the iWatch system in these white squares or diamonds. One can see that the Ahmed group tended to have more outliers in terms of elevated IOP compared to the iWatch system. Additionally, the complication rate was also much lower in the iWatch group. There were no reported choroidal effusions, hemorrhages, or diplopia in this group of 9 compared to the Ahmed group, which did have a few of each of those cases. So it could be a very powerful new device to help eliminate some of the headaches in the postoperative care.
James, this is very similar to LP and VP shunts that have a very similar magnetic type of controlling mechanism.
Yes, that is right. And this is kind of that dial here where it just goes up against the implant and is used to rotate and close off some of the tube.
Let's complicate it.
All right. Next, we have a case of a tube erosion repair.
Do we have questions, Joanne? Let's stop there.
Sure.
I apologize. I had some technical issues, so it looks like it erased all my questions. If one of you all doesn't mind jumping in where we left off.
So Chuck Yang, one of my very first fellows, actually, he was my first fellow. Has anyone tried to exchange an Ahmed ClearPath 350 for Ahmed valve Epi7 for apoteny? If so, would you place Epi7 inside the original capsule or outside? Yeah, so I've gone both ways, Chuck. Gone from a large device to a smaller and vice versa, to a valve device. That's really so the same. I think it's easier. It's probably a little easier going that direction from a Baervelt or ClearPath to an Ahmed because the capsule is longer. When you have an Ahmed there first, you really you have to break posteriorly fairly far to open up the capsule, and you're getting close to the nerve, so you got to be careful when you're going that way. But I typically will place this on the top of the inside of the original capsule. How do you decide to use a Barvelt, Len Rappaport, or ClearPath? As it seems I'm doing ClearPath more frequently. Yeah, so good question, Len. I still, in fact, we're starting, that's a good segue to we're doing a prospectus trial here at Duke. Should start up pretty soon, where we're randomizing patients to 350 Barvelt or 350 Omnic ClearPath. And we're going to take all comers and hope to see if there's a difference between the two groups. In this case, where I needed exchange, you're a little limited somewhat the ClearPath because the anterior foot plates. So in the case of the exchange, I felt because the Barvelt plate was further back, I had more space to work with. I do have some pause of compensation with that previous up curve of the ClearPath that, again, as I mentioned, has been taken care of with new packaging. Another question, can you detail how I'm using a 9.0 nylon wick? Or are you just placing a piece of the nylon in the venting slit and leaving it there? Yeah, so in my experience, I placed 2 venting slits with super sharp, 15-degree super sharp blade. And on either side of those venting slits, I placed probably 3 millimeters of a 9.0 nylon wick in front of those venting slits and behind those venting slits. You're leaving about 3 millimeters in there. And on the last webinar, you should pull that up. We showed how you get nice wicking of aqueous right through that nylon. We tried to look at this with 7 micro, but didn't see good early post-op control in our published paper. But this technique is impressed for general glaucoma. And final question for those doing ClearPath, have you noticed any difference in the rate of apoteny or blood morphology compared to Barvelt? To be determined, and we'll let you know with the results of the Duke study. Okay, James.
All right, again, next we have a case of a tube erosion repair. So this was a 80-year-old female with severe POAG in both eyes. She had an OMID placed in the left eye with good pressure control. However, after 2 years, she eventually developed a tube erosion. There were no signs of infection or inflammation. This is generally what it looked like at the slit lamp. And I guess what would we do next in this instance?
Well, Julia sort of mentioned her approach to recovering these. And this is a fairly wide area of exposure. And I think in this case, you'll show it has this white material in the tube. Yeah, I've seen that. And you get concerned maybe that's an infection, but we'll see what Stuart, I think Stuart, this is your case?
It is. And James was also in the case as well. They're a challenge because if the erosion is close to the limbus, you don't have much conj to work with. So it's very important to do a very extensive conj dissection, particularly up to the limbus, taking care not to violate conj. So, you know, I think we've all probably done these kinds of patch graft repairs, basically dissecting. Then as we're removing the tube, we saw this white material, probably fibrin. We had planned to put a second tube because this tube we thought just wasn't working anymore. So we thought, well, maybe we can get this material out and see if we can restore flow. So we first tried to just kind of squeeze it out. It didn't really go. And then we said, okay, what if we could make a little slit over the top of the tube and see if we can just pull it out. So we tried that a few times and without much success.
Yeah, I'm not sure what this material is. I've seen this. It's doesn't seem to be infectious, but definitely inflammatory.
Yeah, the material years ago I pulled it out of the tube and put it on a glass slide. They're just proteins. they look like they're probably more, we didn't stain them or anything, but they just look like protein aggregates. Usually you can just flush them right through the tube and they'll go back
what
out.
we did. We put a 27 gauge cannula in and was able to flush anteriorly, also pulling it out. And then there was still some material posterior. So we decided to see if we could do a little just cannulation. So we took fluoroproline and just kind of had a pretty good, easy passage into the capsule. And then you can see some flow immediately start coming out of the tip. And just for good measure, I went in just to make sure that was nice and wide open. Didn't go in too far.
What type of tube was this device?
It's an Ahmed.
Okay.
And then flushed it. The blood came up beautifully, and then we just proceeded with the closure. And she's done very well without a second tube, by the way.
And what patch graft material did you use?
I used pericardium.
Okay.
So yes, post-operatively, she pressure was 10 on the first day, vision stable at 20/70, and then at 3 or 2 weeks out, pretty much the same thing too. Tube was well covered, no leak, and there was nice fluid over the plate as well. Next, we'll have a case that was managed by Dr. Nguyen. In brief, this was a man with a history of birdshot uveitis. He developed poorly controlled pressure due to steroid-induced IOP elevation. Eventually, he required a trab with mitomycin. On his exam, the trab site had scarred down at about 6 months out after his surgery, and his IOP was still above goal. So in a case like this, what might be the next step?
Let's go ahead, in the interest of time, go ahead and see the video.
Sure. So an Ahmed was placed. Unfortunately, it eroded through a couple times throughout the year, in part, presumably because of the history of mitomycin. So at this point, we have that tube erosion. Dr. Nguyen goes ahead and removes that tube with some interesting closure technique as well.
Okay,
Well,
Joanne.
I thought this was a good case to illustrate. There's a number of ways of handling the resulting sclerostomy opening when you're taking out a tube or repositioning a tube. At Duke, I was taught to just try and close it with a big horizontal mattress, but I was never quite as skilled at getting a watertight closure with that. And so I like this technique. We're basically putting a figure of 8 around the existing tube using a 7/0 vicryl. I pre-placed the knot there, and then I cut a wedge out of just dry tutoplast sclera. And as you're pulling the tube out, you quickly insert that wedge of tutoplast, and as it hydrates, it'll actually nicely plug that old sclerostomy. And then you can tie down the wedge with the pre-placed suture. And so I found that's just a nice way of ensuring that that old sclerostomy is nice and closed before you move on and reposition or move on to the next surgery.
That's a nice pearl. Samir, do you always ensure that the sclerostomy is closed, or do you let it close on its own?
I think we alluded to this earlier. I'll put a scleral patch graft over it. And sometimes I will even make a little scleral flap with the host sclera and reflect that anteriorly. And then just put a large flap. And if I can't get sutures through it, I'll use TCL glue. But this wedge technique is a neat idea.
Yeah, I typically don't. When I reposition these to a different sclerostomy, I make sure a patch graft is over that. I typically don't close the original sclerostomy. I do tell my fellows that we can prepare for a little low pressure post-op day 1, but those original sclerostomies, in my experience, always do close down.
I don't have fellows, Leon.
Oh, that's right. That's a nice tip. Next slide.
So case 9 would be a case of overfiltration resulting in hypotony and the need for an implant revision. This is her history, severe POAG, history of TRABs in the past, but those have scarred down and pressures are still above goal on maximal medical therapy. These are her fields: severe disease worse in the right eye. And so she was referred for surgical management. In this case, we elected to go ahead and do a ClearPath 350 to help with that pressure control. She was doing well, or she was doing all right the first day, but the pressure was elevated. There was some blood clot around the tube, which may have contributed. Unfortunately, things took a turn in the other direction at week 4. She went down in terms of her vision to hand motion vision. IOP was 5 and the AC was shallow, and now she had choroidals. So all her IOP drops were stopped at that time. I believe, excuse me, I think she was taking more IOP drops than intended. So we were hopeful that stopping all the IOP drops would correct the ship. Started on atropine, but unfortunately 2 weeks later, things had not changed significantly, and now the choroidals were more kissing choroidals. So at that point, she was scheduled for the OR for tube revision and choroidal drainage, and we have that surgical video here.
Yeah, a complex case. You can see a little exposure of the ripcord there that we pull and trim, and we're about 6 weeks out from the ClearPath 350. And it seems like this opened up early. That was hard to follow her post-operatively. She wasn't the best compliant patient, and her family had fairly not the best family support. So we weren't always clear what drops she was taking. But when you have these overfiltering tubes, you try to find out where's overfiltering. And in this case, we decided to tie it off with a 7/0 vicral suture. I think James showed some data with you earlier with our previous study years ago, where you can tie these off with Prolene, you can tie these off with Vicryl. But in this case, we did tie it off the 7/0 Vicryl, thinking that we just needed a little bit longer for the capsule to form completely. So that's the first step. So she's got appositional choroidals, and once we got that tied off and got some pressure in the eye now, we're gonna drain her choroidals. And so I like to use an anterior chamber maintainer.
Leon, did you tie the tube off ahead of the ripcord?
Head of the ripcord. Let's see, what did I do?
So
yeah,
initially, yeah, it was tied ahead, but then it sort of,
right.
She jolted.
Yeah, so yeah, let's stop, pause, go back a little bit, James, if you can. Yeah, so I like to tie these off right over the original ripcord. You can use a Prolene there, but I think what happened in this case, we had a leak through one of those venting slits. I think so. I did have to do an anterior. And yeah, she did move there, and then you see the tube came out. And we can talk about the drainage technique.
But afterwards, the ligature was tied over the ripcord, as Dr. Chawla had mentioned.
Dr. Howard was wondering what was the thought process of tube over trab in this person, since they had such a long success with a prior trab? Was the age a factor?
Age was a factor, and I wasn't sure how she would do post-operatively with management issues. Clearly, I think it's safer to go with the tube than the trab, typically, but not in this case. The question was 350 versus 250. Yeah, you know, in retrospect, 250 would have been a better option here. I think there's very little data comparing 250 to 350, but it would stand the reason there are probably fewer complications with a smaller device. So I mark 3.5 millimeters on the sclera. We'd take a 64 beaver blade and just make a vertical incision. You've got an anterior chamber maintainer running, and I like to use combination of 0.12 and Calibri forceps. Again, this super sharp blade that you've seen a lot today, we cut down into the suprachoroidal space, and once you're there, you'll see a nice efflux of clear material, serous material there, and you just sit there and let it drain. I sort of fish mouth the wounds either side, and we do the same thing on the inferior temporal quadrant until you can tell by looking with the indirect ophthalmoscope that there's good resolution of the choroidal. And the plan is not to get all the choroidals to disappear. You just want to make sure you're getting at least most of the fluid out. Anybody do their drainage differently?
Now, sometimes I'll use a Kelly punch and punch out a hole so it'll keep
Right.
draining.
Right.
And sometimes you can gently take a cyclodialysis spatula and kind of work it right under the sclera at the edge to get more fluid going.
Right.
Okay, so post-operatively, she's been hanging in there, kind of fluctuating with her vision, but it is stabilizing. The chamber has deepened, and most recently we saw her last week. Though she still has a few persistent peripheral choroidals, her pain and vision are both improving, and we're continuing to watch her closely. So we do have one more if we have the time for it.
Yeah, this is a case. We have a lot of our international friends. This is a case from Anthony Okeke, who did an international fellowship with us, and he's from Nigeria. And this highlights the concerns with these tubes if you don't have adequate material. So let's talk about this last case.
Sure. So the patient is one with severe POAG in both eyes. He's had trabeculectomy surgery before. On his exam, however, his pressure is above goal and his vision is beginning to decline, particularly in the left eye. Those traps have scarred down, as mentioned. So the decision at this point is what would be the next step. And in particular, are there different options or different considerations in terms of practice patterns internationally?
Well, we mentioned at the last webinar that the Audi device is very similar to the Barvelt. And Samir, have you had any experience with the Audi?
Yeah, actually, interestingly enough, the group at KCASH, we just published this in European Journal like 5-6 months ago. We had the privilege of having the Audi and the Barvelt. So we just did a head-to-head comparison with the cases we did, and it works just as good. I mean, there are some manufacturing issues early on with the tube plate junction, but for all intents and purposes, it's like a Barvelt. It's a little more flexible, which actually makes it easier for training. So the Audi is a lot cheaper. It's like $45-50. So I really like the Audi, especially in Indian, African populations that have fibrosis. You don't have to worry about the valve issues, and the cost is a huge advantage. So I really like it.
I think that was chosen for this case, James.
Yes, that's correct. So that implant was placed, and initially, again, he did pretty well. However, at 6 months out, things began to decompensate. The cornea has gotten a little hazy. There was peripheral KNV, and the AC was shallowing. On top of that, the pressure in his right eye has begun to creep up also. So a challenging situations where we have two things going on at once, one in each eye, and wondering what people would do next in this instance.
Probably Audi in the right eye.
So this is where our colleague from Nigeria is sort of left off. It is yet to be determined what the next steps will be. It seems reasonable that the right eye would get a similar implant, but then the left eye may need some further management as well and close monitoring.
No, actually, the patient did have an Audi placed in the right eye, and now the pressure's up, I believe, James, now after the Audi was placed. So now the question is the inferior tube, and his question was, well, if I place an inferior tube, should I do an inferior tube or should I do a micropulse? If he places an inferior tube, of course, I like to use the corneal patch graft, and he doesn't have that available. Does any of our panelists have experience with cutting a scleral flap for inferior tubes, Samir?
And so I alluded to it earlier. If you use the, like Oscar Albus, the Mexican study that looked at just using I believe a 23 gauge needle, and you start back 7 millimeters posteriorly and you can tunnel anteriorly. What I do is a modification where I stop about 3 millimeters, use a scleral cut down with a 15 degree. Then I'll make a little scleral flap at the limits because I find it very difficult with that long needle technique to have good tube placement in the anterior chamber. My tubes tend to be too much in the mid AC with that technique. So it's like a scleral sleeve for 7 millimeters back up to 4 millimeters. The tube then goes under a flap, and then you can aim it, you know, a lot better. And that way you don't have to put a patch graft. So that would be a nice technique.
So you're just tunneling the needle, Samir, and making a flap.
Well, so you tunnel about 7-8 millimeters posteriorly. You tunnel up to 3-4 millimeters, and then you put the tube and have it externalized. Then that remainder, it's a traditional trab flap or a modified flap. So it's like a sleeve posteriorly and then a flap, if that makes sense. So it's all within host sclera, and that can avoid using any patch material altogether. And I do that in high-risk patients that have had exposures. And then here in the States, I do that technique, and then I put a pericardial scleral patch on top just for good measure to keep our attorney friends away in case it does re-expose. I said I did use a patch graft in that case. So you're basically doing a scleral flap technique, but starting back 7 millimeters with that needle as an initial tube entry.
But what's the purpose of your initial pass so far back in the sclera?
Well, you know, most exposures happen at the limbus or 3 millimeters posteriorly. But inferiorly or even superiorly, the better coverage, you know, I feel if you're on host sclera and then you have a scleral flap, there is that exposed tube though, isn't there, from 4 millimeters back to the plate. So, and also it kind of serves as a way to keep the tube stable. You could even argue in some of these sutureless techniques, you may not even need to suture the plate because you've got that scleral tunnel that's keeping the plate affixed to the eye.
So I've just made regular trab flaps and then just put the tube in the AC and just suture the trab flap over it, and it seems to work. That may be one option for them. I don't know if they don't have sclera available as well.
In Haiti, we do a similar technique as Dr. Ahmad describes, except without a flap. You just poke the 23 gauge needle out and then use that same entry to create a deeper entry into the AC. You grab the tube, and it's a little tricky to feed it into the shorter tunnel, but with some patience, you can get a nice long tunnel. And if you want to put a vicryl suture over that, and you can't really see the tube entry, it can be really beautiful, having seen them 3 years later in the absence of patch material.
It's very tricky though, like Shane said, it's hard to get it. So I just make a little flap, a modified trab flap, just to, you know, make it easier to get that tube entry. That's tough to do it all the way with a needle.
It seems like it would be physically impossible to get a 7 millimeter pass of a needle and then get it to be planar with the iris right at the level of, you know, just above scleral spur without doing something like you described.
Yeah, and I've just had 2 cases where I put in the sulcus with that little flap because you have more control. It's very hard with one long needle pass.